Again, calculus left, associated lymphadenopathy, hydronephrosis, dermoid right ovary. So it was well picked up, but ultrasound is not at all a very specific uh, modality. You can never be sure on ultrasound that what this is. Particularly in UK, we do MRs for this, and the correct answer is ask for an MR. Now, in this particular case, if you see what are the learning points here. So findings were well picked up. Just a bit of fine touch that there is a staghorn calculus here, and we can see that there is hydronephrosis. So this was the main finding. But associated finding, for example, there are lymph nodes here. So this is a lymph node, this is a lymph node, this is a lymph node. So, there are signs of secondary infections. Now, these ones were well tackled, that these are focal lesions, most probably cyst. I would like to do an ultrasound for that. It is fine. And this was very well picked up, a fat containing lesion. Now, just on this, you can never be sure that this is fat. And this is fat. You should have asked for densities. You cannot be, is it air versus fat, just to eyeball it. So then the way radiology is practiced, this exam is the way it is practiced in UK, right? So now we do what we call MRs here. Just to highlight that the findings, though I did not show you a coronal, but this is the staghorn calculus. This is the hydronephrosis. You can see all of these lymph nodes here. If you see, there is the fat here is a bit dirty as compared to the right side, means, secondary signs of infection. So this thing, actually, I would have shown you an MR, but because you did not ask for it, I did not. So on MR, this is how it looks like. And please remember, part of this idea is that dermoid MR per se is an exam case. So they can show you a dermoid, ovarian dermoid, just as a single modality. So this is it. And then that was a T2 weighted sequence. It was high signal. This is a T1 weighted sequence. So there is a bit of a solid component here. And then if you go to fat saturated sequence, which is this one, it saturates. So the idea was to pick up multiple findings. You did very well to pick them up. Okay, thank you, candidate 2. We go to candidate, sorry, this was candidate 1. So thank you to candidate 1. And now we go to candidate 2. Candidate 2, are you with us?
Yes, sir.
Okay. So candidate 2, this is history. Look at the history. This is a 66-year-old female, and she has presented with recurrent attacks of syncope, vertigo, ataxia. She also complains pain in numbness, tingling in arms. And on examination, her BP on the right side is 80 by 50, and on the left, it is 120 by 80. So we have done a CTA study from arch of aorta till circle of Willis. So over to you.
Sir, I'm requesting the remote.
You would like, okay, the mouse is with you.
Thanks. Provided axial sections of
Can you speak
brain
up,
and...
please? I can barely hear you.
Sir, am I audible now?
Yeah, better.
Provided axial post-contrast axial sections of brain and neck in an angiogram study in an elderly female patient. I'm going through the images from top to bottom. I'm coming back to the scan. I'm seeing through the bilateral common carotid artery and also the vertebral artery in the proximal section, cervical portion. There is reduced caliber of the right vertebral artery from its origin, likely hyperplastic. I'm looking through the ICA now, bilateral ICA.
Speak up, please. Once again, you are barely audible.
Okay, sir. So the right, I'm looking through the right internal carotid artery. Okay. I could appreciate a thickening involving the bilateral cavernous and supraclinoid segment. Other than that, I'm looking through the MCA now.
So let me tell you that there is no abnormality in the intracranial vessels. So
Okay.
concentrate elsewhere.
Coming back to the next sections again. There is atherosclerotic changes involving the arch of aorta, and also looking through the origin again, the common carotid artery. Common carotid arteries show normal opacification in caliber on both sides. I'm looking through the proximal cervical portion.
Okay, look at the arch of aorta once again.
Okay. There is sclerotic calcifications and minimal wall thickening, the arch of aorta. Other than
Okay,
that, I could
don't scroll. I'm going to point out to something for you. So I'm scrolling now. What do you think is this? You can
there
scroll
is
up and down if you want.
yeah, there is wall thickening involving the arch of aorta along and the right brachiocephalic and yeah, the right common carotid. So it's possibly a vasculitis
Okay, just
involving
one
the arch of
second,
aorta.
please. 1 second. What is this structure where I'm pointing out? this circular structure, this thing. You
Sir,
can
I'm not.
scroll up and down.
I'm not able to appreciate other than.
Okay, thank you then. So, uh, first of all, let me, show you what it is, and then I'll go through the scan. This is a case of right subclavian steal syndrome. And this right subclavian steal syndrome is due to thrombosis of right aberrant subclavian artery. Basically, there are two findings here. And the first thing is that you have to pick up that there is a right aberrant subclavian artery, and which is thrombosed. And because of that, there is subclavian steal syndrome, which can explain the symptoms. Now, quickly, a few details. There are two different things here, rather three different things here, which can happen or which happen around this. Right subclavian, uh, right aberrant right subclavian artery, actually, it arises distal to the left subclavian, and it can pass posterior to the esophagus. It can pass in between the trachea and the esophagus. It can pass anterior to the trachea. When it can pass posterior to the esophagus, it can be compressed, and it can also cause dysphagia. We call as dysphagia lusoria, which I'll show you. And then it can be what we call cause thrombosis also. So whatever I'm showing is from Radiopedia here, so you can revise it from Radiopedia. Aberrant right subclavian artery, uh, also known as arteria lusoria, and that is why we call it, when it causes dysphagia, we call it dysphagia lusoria. Incidence is, it is one of the most common anomalies of the arch of aorta, 0.5 to 2%. And when it is retroesophageal course, it can be compressed between the esophagus and the vertebra, and then that can result in its stenosis and occlusion, in addition to the dysphagia, which can help in it. Now, mostly it is asymptomatic. In 10% of cases, it can cause dysphagia lusoria. And this is what I have told you already, that the course can be posterior to the esophagus, 15% between esophagus and trachea, 5% anterior to the trachea. Subclavian steal syndrome. Concentrate on this diagram and it tells you everything. Now, if you see here, when there is a stenosis or the thrombus of uh, subclavian artery. This one, the diagram shows you left side. Our case was right side, and of course that was aberrant. So what happens is, please remember that the vertebral arteries, they are arising from the subclavian artery. So the steal phenomena happens. How does it happen? Steal of blood from actually intracranial vessels. So, and these patients are very interesting because at times the symptoms are when they are using that arm. For example, even a Tesco worker who is, doing some shelving work will present, suddenly with this, dizziness and collapse and things like that. Why? Because there will be shunting of blood or stealing of blood uh, from the circle of Willis posterior through the posterior communicating, etc., and it will go down through the vertebral into this subclavian. So there can be there can be uh, two entities here. Look at this; these words: subclavian steal phenomena. Basically, when the finding is there, but symptoms are not there. But when there are ischemic symptoms, then we call it subclavian steal syndrome. And so these can be the symptoms. They can be of ipsilateral upper limb, weak or absent pulse. Systolic blood pressure can be affected. Systolic blood pressure might be 20 mm less than the other side. There can be claudication when the patient is using that arm. And there can be neurological symptoms, dizziness, ataxia, visual change, dysarthria, weakness, and sensory disturbances. And just for your knowledge, our case was not with clinical history of dysphagia, but it can happen, and it can happen in 10% of cases. It is a very difficult diagnosis, and usually a diagnosis of exclusion. And sometimes the patient present with severe cough. In children, they present with stridor. So, with that, let's go back to the case. Now, so on this axial, we can, this is the arch of the aorta, and we uh, can see something here. You see this thing? And when we scroll up and down, it is not in continuity with anything. So this is and if you see, this is the esophagus, and this is the artery. And then there is a calcification here, means, so I've gone to another window just to highlight it. And then if you go further, you can actually, this is what I was pointing out. Uh, if you trace it, this is a vessel. And then what happens? This vessel continues, and suddenly there is a dot here. And then this is the subclavian artery. Now, superior to that, if you see here, you know, look at the vertebral. This small dot is the vertebral. And if you want to trace it, where my mouse is, I'm pointing to it, you can see it going into the vertebral foramen. So this is the right vertebral. And just to make a point that on the left side, this is the subclavian, and in comes more chunky uh, left-sided vertebral. And please remember, right and left vertebral can be also a normal variant. This one will be smaller as compared to the other. So don't overcall it. But in this case, this is the vertebral. And you can well imagine that this vertebral is causing the steal phenomena, and that is what it is. Same finding you can see on this is coronal sequence, and on coronal, here you are, this is the vertebral, and on sagittal you can see it, but axials, as I pointed out, were good enough to diagnose it. So where I'm pointing out, this is the subclavian, and then you lose it. So, and this, where I'm pointing out, you can see this vertebral going up superiorly, but the axials were fine. Okay. Next case. Over to you, candidate 2. This is 76-year-old female presented to A&E due to unwitnessed fall. She is confused. She has got history of weight loss, tiredness, anemia. She is not well, but she just fell down, and that is why she came to the hospital. Over to you.
Provided frontal projection radiograph of chest in a skeletally adult female patient. Striking abnormality I can see is a area of ill-defined opacity, which is projected over the uh, right upper portion, which is broad based to the chest, or it is broad based toward the chest wall and projecting into the lung parenchyma. I can't see any calcification within it, and the overlying ribs show some sclerosis compared to the left side. Other than that, I can also appreciate some surgical staples on the right lower portion, right lower lung field. And looking through the rest of the lung parenchyma, I could also appreciate a small nodule in the right perihilar location. Um Bilateral costophrenic cardiophrenic angle is normal. There is mild widening in the superior mediastinum. I'm looking through the rest of the bones also. So breast shadow I can't appreciate actually on either side. Rest of the bones also show no obvious focal lesion. So there is an ill-defined opaque radiopaque lesion broad base to the chest wall on the right upper portion with associated mild sclerosis of the overlying ribs. So it could be with the provided history. It's more looking like an aggressive lesion. It's a aggressive chest wall lesion, and the other possibility could be a hematoma. And I would inform this finding to the referring clinician. I will further evaluate this patient with the CT thorax. If any
Why do you say
non-underlying malignancy, I would think of metastatic lesions.
why do you say it is an aggressive lesion?
It's a wide. There is a wide zone of transition
Between
between the chest, the scapula, and the lesion.
and what does that mean?
It's possibly arising from the scapula.
Anything happening to the ribs?
Yeah,
What is happening to the ribs?
there is sclerosis of the ribs on the right side, and
You like to
I can.
do something else to look at it better in a better way?
Yeah, I would check it in the zoomed up image, and there is overall volume reduction in the right side chest wall also, right lung parenchyma also. Okay.
So, have you picked up anything new?
I could also see some lytic areas in the anterior posterior margin of the right first second rib.
And where is the lytic area?
This
Which rib?
first, the posterior portion of the first and second rib,
Right. So now what is your conclusion?
possibly a metastatic lesion, or otherwise it's a myeloma lesion. So I would check the spine images also to confirm it, or I would
So if it is a metastasis, then from where it is coming?
breast lesion. If
Why do
not
you say that?
visible, other thing is, there is a I can't appreciate the breast density. I mean, sorry, the breast. I can't compare the breast parenchyma. It's not clearly seen in the image. So yeah, and then I can also see some um, surgical staples and clips on the right side. So that's possibly a secondary to mastectomy. If there is any history suggestive of that, then it's possibly a metastatic lesion.
Right. What would you like to do next?
I would compare with the previous images if available. I would further evaluate with the CCT for CCT chest and upper abdomen.
Over to you.
Thank you.
Mouse is with you.
Thanks. Provided post-contrast axial sections of chest and abdomen in the same patient, going from top to bottom. Going back to the lesion where seen in the right chest wall, the upper chest wall. Okay, the lesion shows heterogeneous enhancement with the area of necrosis, which is ill-defined. It is located in the anterior anterolateral chest wall, possibly arising from the ribs. I can't see the rib, the involved portion.
Say again, please.
Yeah,
You cannot see what?
overlying ribs on the right upper portion.
Which ribs?
So, okay, there is marked restriction of the first, second rib, first and second rib.
Okay,
And
so what is your
the,
final conclusion then?
there is a large heterogeneously enhancing soft tissue lesion associated with the marked restriction of the ribs on the right side, right first and second rib. So it's possibly metastatic lesion. I will let me check through the.
What else can it be?
Then it could be a primary aggressive bone lesion.
Like what?
There is no matrix. There is no matrix mineralization. It could be a sarcoma.
What kind of a sarcoma?
Soft tissue sarcoma.
Anything else?
That's all I can think of.
Okay, thank you. So this was this basically is metastasis from breast. So it's an observation case, but it is also a story case. And the main thing is to pick up the story. And story cases are very important for the exam. The story is that you can see metallic clips here, and these metallic clips tell you that something has happened. Definitely, it's not a complete mastectomy. Maybe partial mastectomy has been done. But these metal clips are the key. Now, with that, there is an opacity here. This opacity is destroying the first rib. Definitely. If you see here, so, the key things in the exam, what you can do, you can mag it up, ask to mag it up, change densities, things like that, ask for these things. So this is the T1 vertebra, and this is the first rib. And this is the T1 vertebra, and this is the first rib. Actually, you just lose it. It is all eaten up. And the second rib, which is overlapping, is also destroyed. So that was the key finding. So just on this plain film, one can make that diagnosis. Now, uh, uh, for revision, there are the differential diagnosis which you can revise here is this one from Chapman 5.45, focal rib lesion, solitary or multiple. So rib metastasis, and then, sometimes there is a new plastic process which is arising from the from the lung, from, let's say the lung cancer. In this case, it was not like that. Mesothelioma, lymphoma. Uh, this was definitely not a multiple myeloma or a plasmacytoma. Even sarcoma, etc. The age group is different. That is in young patients. So remember that. And as far as CT is concerned, even here, the same findings can be again seen as we picked up there. But now this is the rib. This is the first rib, and you can see how it is just destroyed. It is eaten up. And this is the second rib, and this is also destroyed. And if you look at the breast once again, you will see, these clips, and you can see a bit of a partial mastectomy type of appearance. By the way, this patient also had an adrenal nodule, presumably metastasis. Right? Thank you, candidate 2. Candidate 3, are you with us?
Yes, sir.
Okay. So, the chest cases which I showed you today, these are classical observation cases. And many a times the Viva starts with things, cases like this. So this is a candidate 3. This is a
Yes, sir.
77-year-old female, again an A&E case. Uh, the patient was, she fell down in her bathtub, actually, hit her head, and she has got occipital region, scalp hematoma, eyebrow, scalp hematoma, dizziness. So that was the impact on the skull. So over to you.
Okay, I've been provided with CT's head plane of axial section of a patient who has history of trauma. I'll just scroll through the images before I start describing the findings. Okay, starting from down up, the bilateral cerebellar hemisphere appears normal. As I'm going up, the medulla, the pons appear normal. The midbrain appears normal. The bilateral occipital and midbrain appears normal. I'm seeing some air foci within the brain, which may represent pneumocephalus. I'm going up. The uh, bilateral middle temporal lobe, frontal and parietal lobe appears normal. There's also air within the frontal horn of the lateral ventricles, which further indicates pneumocephalus. As I'm going up, I'm trying to look for any intraparenchymal or extraaxial hematoma, which I didn't appreciate on my first look. So there was no evidence of any intraparenchymal or extraaxial hematoma. However, I could see there were multiple air foci which were located within the around the basal cistern, suprasellar cistern, and also within the third ventricle, frontal horn of the lateral ventricles. So there's pneumocephalus. Apart from that, I can't see any hematoma. Uh, as this patient has history of trauma, the orbits, I also look at the orbits. There's no evidence of any humosinus within the maxillary sinus, and the orbits appears normal. In my routine practice, as this is a trauma case, I'll want to look at the bone window to look for any fractures.
So on
um,
bone window, there were no fractures.
okay, so I'll just go through my review areas once again. um, there's no evidence of any extraaxial hematoma, no evidence of any intraventricular hemorrhage. um, there's pneumocephalus. Apart from that,
Okay, what you are referring to as pneumococcus, can you point it out to me?
okay, sir. There are two air foci within the frontal horns, and as I'm going down,
So can this be anything other than air?
this could be okay. As I'm seeing a MCCT scan, these could represent some fat globules as well. In my
What can you
routine,
do to?
practice, I'll measure the HE of these lesions to check whether it is fat or air.
So this
If
was
it is
minus 40 Hounsfield unit.
okay, so as it is minus 40, I'm suspecting a fat containing lesion which has disseminated. So it could be a ruptured dermoid and which are causing multiple air foci scattered within the cistern and the ventricles. So this is a case of a ruptured dermoid. I'll check the previous investigation of the patient. I'll suggest a CCT head as well, and to check
What will
the
you suggest?
confirm and now MRI
Excuse me.
contra. Yes, sir.
What kind of CT you said you will suggest?
I'll check post contrast CT just to check any enhancement if it is there. I should check a MRI brain to look at the fat content of the lesion.
Okay,
Uh,
so I am going to show you an MR of the brain, but the point is that what sequence would you like to see?
I would like to see a T1 weighted image, and then I would like to see a T1 fat sat images to confirm whether it is suppressing on the fat saturated image or not.
Right. So this is a T1 for you? No,
Okay, sir.
it's not showing. It's not showing for you. Just 1 second, please.
Okay, sir.
Don't move
Oh,
your mouse. Sorry, there is a constant technical issue at my end, which is over to you. Sorry for that.
okay, sir. I've been provided with Excel T1 weighted sequence. I'll scroll through the image once before I start describing. So I'll ask for remote once again.
Yeah.
Okay, now I can scroll. I'll go up to my concerned area. So yes, there are multiple T1 hyperintense foci which are seen scattered within the brain parenchyma. One adjacent to the right frontal horn. One is seen in the left corona radiata region. as I'm going down, there are multiple foci. One is seen in the midline in this cistern area, and multiple other foci are also seen within the suprasellar and the basal cistern region. So these T1 hyperintense lesions could represent multiple fat globules. I'll check on the T1 fat set sequence as well whether these lesions are showing suppression, and there's no other perilesional edema, and there's no other areas of hemorrhage I could see, and the rest of the brain parenchyma appears normal.
So, what is your conclusion now?
So
What has
my
happened?
conclusion is it is a case of a ruptured dermoid, and
So, where is the dermoid?
uh, the dermoid is I think the dermoid is within the suprasellar region, which has, after being ruptured, has disseminated in the surrounding areas.
This is the suprasellar region.
Yes, so there are multiple. There's a heterogeneous lesion with multiple T1 hyperintense foci, which is seen within the suprasellar region. So this would have been a suprasellar dermoid,
Where is the
which is
suprasellar dermoid? You can see multiple droplets.
foci.
So, where is the parent dermoid?
The parent dermoid, few T1 hyperintense foci I can also see in the cellar region, and cellar and the supracellar region, and
Can it be from what will you do?
um, next I would see a T1 fat sat sequence, and I would also see a post contrast sequence to check whether there's any enhancement or not.
Post contrast has got no role. There will be no enhancement. Okay, I'll take over now. Thank you. So, this is a case of ruptured dermoid. Now, the patient, of course, had these locules which appear low density. There was a bit of a history of trauma. And one of the key points here is that you picked up the finding very well, but you assume that this is pneumocephalus. So that was a catch in this case. And of course, this is what will happen in the exam also. The examiners don't have time, so they will guide you that on bone window there was nothing. So once you pick up the finding, now you start looking for the dermoid. Now it's fine to ask for MR, which is what it is, that on MR, on T1 weighted sequence, you can see, first of all, on axial, the same thing actually. Now this droplet has slightly changed location. This one is there, and then in the suprasellar region. But where is the dermoid? So the key point here to remember is that in these scenarios, you have to ask for spine imaging, because the dermoid will be sitting there and will go up from there. And this is what you should have asked. Actually, in this case, the dermoid was in the sacral region. And you can see that these are three fat, fat droplets, and on a fat saturated sequence, this is a T1 fat saturated sequence, it shows signal dropout. So that is the key message from this case. So please remember, ruptured dermoid causes chemical meningitis, and it can have its own morbidity and etc. Sometimes it is just asymptomatic, doesn't cause anything. Okay, so candidate, this is candidate 3. This was your first case?
Yes, sir.
Okay, now this is your second case. This is 76-year-old male, increase PSA nocturia. Over to you.
I've been provided with Exil, uh, T1 weighted, T2 weighted sequence, Exil section of a male patient. I'll just scroll through the sequence before I start describing my findings. At my first glance, in this limited sequence, I can see that the prostate appears enlarged in size. It is diffusely T2 hypointense with few T1 hyperintense lesions within, which may represent nodules of benign prostatic hyperplasia. In my routine practice, I'll check for any T2 hypointense lesion and also the diffusion weighted and the post contrast sequence to rule out any prostatic carcinoma. Apart from that, I would like to check the rest of the areas as well. Apart from the prostate, the seminal vesicle appears normal, and the bladder shows mild wall thickening, otherwise it appears normal. Um, the Coming to the bones, there's the bilateral proximal femur appears normal. The bilateral iliac bone shows some fatty marrow signal. I think that's normal. Apart from that, I'll check for some any suspicious lymph nodes, if any. So there's no any suspicious lymph nodes. The visualized rectum and the sigmoid colon appears normal. Uh, in my routine practice, I'll check the other sequences as well. The diffusion weighted, the T1 and post contrast T1 fat
So
sat.
which area are you worried about, and what is, just conclude the case? What is your suspicion here? I will tell you the findings on other sequences. Once you tell me.
There's enlargement of the prostate, and there's ill-defined T2 hypointense area, which is seen within the peripheral region of the prostate, which is my suspicious area. So I would like to check these areas on diffusion weighted and post contrast sequence.
Point it out to me. Which area
So
are we talking? This area.
here,
So
yes, sir.
this showed restricted diffusion.
So if this area is showing diffusion restriction, and as this area is located within the peripheral of the gland, so I'm suspicious for a malignant prostate lesion. And I'll also check the T1 pre-T1 and FATSAT and T1 FATSAT post-contrast sequence to look for any enhancement. And if the lesion is showing any enhancement, I'll be confirmed that this lesion is a suspicious lesion and suggest a biopsy correlation from the lesion.
So what is it confined to the prostate?
And yes, I have to further stage the lesion. So on the left side, the lesion is showing some periprostatic fat stranding and some extra capsular extent within the surrounding fat, periprostatic fat. So this is showing extra capsular invasion as well. However, it is away from the bilateral seminal vesicle, and it is not showing any bladder wall invasion. So I think it is a T2 lesion with periprostatic extension, and I'll discuss this case with the genitourinary team and discuss further management. Suggest a bone scan to look for any other bone mets, and CT for local staging.
Okay, thank you.
Thanks.
Now, this is a case of prostatic carcinoma with capsular breach, left seminal vesicle invasion, lymphadenopathy, bone metastasis. And I'm going to go into a rapid fire, teaching type of a mode. it is not a session just for prostate MR, which we can do in future, but I will rapidly go through a bit of teaching of prostatic carcinoma MRI. Please remember, prostate carcinoma MR is, you should know it for your exam, just like rectal carcinoma. So now in here, just quickly a bit of a recap of the basics. So this is the prostate. It sits, this is the bladder. The prostatic urethra passes, this is the membranous urethra, which passes through the urogenital diaphragm. This is the seminal vesicle, and these are the ejaculatory ducts. Now, uh, there are various zones of prostate. This orange one is the central zone. This green one is the peripheral zone. This yellow is the anterior fibromuscular stroma, and around the urethra is the transition zone. Now, transition zone is very small on this diagram, and which is in young age group, but usually you will see prostatic carcinoma in older age group, where this blue zone will be large. Now, considering these three words should be in your vocabulary, and you should have a clear-cut idea which part of prostate we are talking about. Three areas or three zones, not zones, but three levels, should I say, should be in your mind. And this you should keep in mind for your reporting also. So at the where the prostate is sitting on the bladder, you call it the base, then is the mid portion of the gland, and then distally is the apex. Now, the zonal anatomy changes, which is depicted here, and you can revise it later on. But just to highlight that this green zone is in all of these areas. So starting from the base till the mid, from into the mid portion and into the apex, it is larger. Look at this yellow zone, which is the anterior fibromuscular stroma, and this is anterior to the urethra, and it decreases in size. Tumors do not uh, originate in this zone. 70% of the tumors, they originate in the peripheral zone, and at FRCR level, you expect to be shown carcinoma cases in the peripheral zone. And to the upper part, proximal part of the gland, which is the base and the mid portion, is this central zone, which is the orange zone. But distally, there is no central zone. So this is the same concept on a coronal, where you can see this, the central zone, this blue one, which is the transition zone, and this is the peripheral zone. Now, how does it enlarge? Just concentrate here on this. This is the transitional zone or the transition zone. And when there is PPH, this is what happens. So I go back, small, and now it is become so large, it is compressing everything. So this is usual for you to see, prostatic hypertrophy. Now, this is 4 different patients. So if you see here on a T2 weighted sequence, the peripheral zone is high in signal intensity. And this is the transition zone, which is similar. This is a young patient. And then we have got PPH here. We can see the peripheral zone, which has got high signal. And the transition zone is this one, heterogeneous signal with hypertrophic nodules. Now, another patient, and you can see that the transition zone is further enlarged, and this is a classical appearance of PPH. And this, of course, is the peripheral zone. And now there is gross prostatomegaly, and you can see that this is the transition zone and the peripheral zone is compressed. So please remember that tumors can happen in the peripheral zone 70%, 30% in the transition zone. We do MR with multi-parameter MR, we call it. And here the key sequences are T2, small field of view T2s. You must see axial, coronal, sagittal, and then see the DWI sequence. In the DWI sequence, I'll come back to the interpretation. Right now, just concentrate on the sequences. And then a T1 weighted sequence for metastasis, because T1 is the best sequence. Some departments do upper abdomen also. Some do not do upper abdomen when they do prostatic scan. And you particularly have to rule out any para-aortic adenopathy. You have to rule out any hydronephrosis in the upper abdomen. Then we do dynamic post-contrast sequence. And this is the protocol and dynamic protocol where 15 measurements are taken, 10-second pause after the first measurement. So this is the protocol, but for your exam, T2 weighted sequence is where the exam will be. Now, this is a classical case of a carcinoma. If you see, we are at the apex, and you can see this low signal on T2, which shows restricted diffusion, bright on DWI, low on ADC map. It shows early phase arterial enhancement and then delayed washout. So this is a classical carcinoma picture. Early enhancement is what we are talking about. Having said that, even if you don't have a post-contrast sequence, you can still diagnose a carcinoma on the basis of T2 and DWI. I'll come back to this point. So prostatic cancer staging, this is where the exam will be about T3A and B, or gross, T3A means extracapsular spread, and B means when it is invaded the seminal vesicle. If it invades the adjacent structures like bladder, neck, external sphincter, rectum, pelvic wall, then it becomes a T4. This is from your book, and from Chapman 9.41, prostatic lesions. And please read it once again from here. Same points which I have told you. The key point is the T2 hypointense plus restricted diffusion plus early enhancement and washout. So it is easy to detect in the peripheral zone. And so for FRCR exam, key points I'm repeating: low on T2, restricted diffusion, and if post-contrast is provided, early enhancement. This is what we are talking about. Also, these should be your pertinent points which you must mention in your report, and your eyes should go and try to search for these things. So peripheral zone tumor, this is my point is that this is most likely in the exam for the simple reason it is more easier to pick up. Doesn't mean that they cannot give you a transition zone. Then capsular breach, it has to be part of your report. Is there capsular breach or not? Seminal vesicle invasion, part of the report, it has to be pertinent, negative and positive. Lymphadenopathy, that should be part of the report, and bone metastasis, for which you should see a T1 weighted sequence. Now, what is the MR criteria for extracapsular spread? And studies have showed all of these, and the fats trending, which you saw in the case which I showed you, that is, I think, one of the easier things to pick up. But you can have a bulge, you can have a bulge of the capsule, there can be retraction, there can be thickening, there can be stranding. You can actually physically see the extracapsular tumor, and some studies told us that if a low signal intensity tumor is abutting more than 12 millimeter of the capsule, then this is taken as a sign of extracapsular spread. But in the exam, they will show you a case in which it is definitely going out of the capsule. It will not be a tricky case. And then, as far as seminal vesicle invasion is concerned, please remember the key thing that just don't go for axial. You have to see particularly the sagittal um, to see extension of the tumor into the seminal vesicle. So axial T2 and sagittal T2 should be your first two, and then should be the coronal T2 to evaluate. In each and every case, you must evaluate all of these. So this is two different examples where you can see this is prostatic carcinoma with extracapsular extension. This is on left side, look at the peripheral zone, it is normal. On the right side, this is low in signal intensity. You can see this stranding, whiskering into the fat. So this is definite extracapsular extension. And you can imagine that the capsule actually is where I am pointing out here. This is another case where there is more frank, this, extracapsular extension. This is the neurovascular bundle, which is sitting here, and it is invaded in this case. Uh, as far as DWI is concerned, this is a potential Viva question. Remember this. Uh, the B value, the maximum B value which is recommended for prostate is 1400. So, and in your department, if you are not following this, you should use B 1400. Please remember that in body imaging, when we do DWI sequence, we increase from B0 to B500. This is the protocol which is done in my department, 500,000, 1400. 1400 is studies have told us that it is the best sequence. So must try it. Please remember that in all body imaging, you don't use 1400. You don't use 1400, for example, in MRE or liver, etc. And there will be variations in various departments. But in prostate, it is recommended maximum D value of 1400. So anything which remains bright on 1400 and low on the ADC map, then you call it restricted diffusion. So this is from radiology assistant, which is bright here on DWI and low on the ADC map. So this is restricted diffusion, and this is classical positive. When you report a case of MR, your report should include the PSA density. The PSA should be provided to you. Remember that. It should be provided to you, and you have to, first of all, measure the volume of the prostate. You can take two measurements on axial or two measurement on the, the sagittal. So you need three measurements. We know the formula, and you should know the PSA, which the clinicians will provide to you. And you've got many softwares. You can download an app, etc. Just put the values there, and PSA density should be part of your report. That the prostate is this much in size, the volume is this much, the PSA is this much, the PSA density is this much. A PSA density of more than 0.2 usually is taken as abnormal. Now, it all depends how not for the exam, but if you are reporting MR prostates, then you should mention in your conclusion your PIRAD score. I don't have time to go into details of it, but we have got 5 scores. Till three is indeterminate, 4 is highly likely to be cancer, and 5, of course, is same, except what is the difference between 4 and 5? Size difference. There is no other difference. So if a lesion is more than 1.5 centimeter, it becomes 5. Less than 1.5, it becomes 4. Also, if a lesion is extracapsular, it becomes 5. So, when you report a MR, you 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 have to give them score, imaging score on T2 as well as DWI sequence. So remember this. And there is a concept of, we call it dominant sequence. Dominant sequence. So for peripheral zone, the dominant sequence is the DWI sequence. The DWI. For transition zone, the dominant sequence is T2. So indirectly, whatever the staging or the score is on a T2, for transition zone, your final score will be that. And in the peripheral zone, DWI will guide the score. So I don't have time to go through all of these, and I think we can do a session separately for prostate MR. But these are the various parameters on which you give it a score 1, 2, 3, 4, 5, and this T2 is dominant for the transition zone. And this is the criteria to give it score on DWI. And so, and uh, another concept to remember is, not for your exam, but generally speaking, if you are reporting MR, that if a lesion can be upstaged, if for example, in the peripheral zone, there is a pyrites 3 lesion and it enhances on contrast, it will make it a pyrites 4 lesion. Similarly, in the transition zone, if there is a pyrite 3 lesion and it is DWI positive, DWI score of 5, overall scoring will change to pyrites 4. So these are, for people who report them, they should know all of these. But for FRCR, basically you should know low signal on T2. You should know the anatomy. Anatomy will be asked in the exam. And you should know this basic, what we call concept, low T2, high, restricted diffusion makes it cancer. And anatomy is critical there. Now, let me quickly go through a normal case with you. So this is a normal case. And here, so I have gone superiorly, and this is the bladder, and I am coming inferiorly. So as I come inferiorly, you can see these two seminal vesicles, and then the prostate comes into view. And you can see that posteriorly, this is the peripheral zone, and there is a bit of hypertrophy of the transition zone. So this is the transition zone, and see that this is low signal. And, these kinds of linear and wedge shape, if you go into scoring, this is not, pyrites 4 or 5, this is pyrites 2, actually, this appearance. So as I go distally, I go towards the apex. And at the apex, you can see this levator sling around it. So I am now going back. And so this is the peripheral zone. This is the transition zone. As I'm going towards the base, so this is the base, and then seminal vesicles, and this is the bladder. Also look for lymph nodes. So look at the pelvic nodes, lateral pelvic nodes, and look around in this region. There can be nodes, pelvic side wall, around the bladder, etc. There can be lymph nodes. As far as bone is concerned, you have to see or ask for a T1 weighted sequence for bone. Now, let's go to sagittal. Now, So this is a sagittal, and so I'm going, you know, this is on the left side of the patient, and I am scrolling going through the right side. So just concentrate on how the peripheral zone looks like. This is the seminal vesicle, and of course, this is the transition zone. I'm going to the other side, and so you can see the seminal vesicle on the other side. So as a habit, you must see all of these. You should see, the axial and the sagittal are the key sequences, T2, but must see the coronal also. And after that, for uh, you can correlate with the DWI. So in this format, the the B1400, this is the B1400, which does not show any restricted diffusion, and this is the ADC map, which doesn't show any abnormality. Coming back to the case which I showed the candidate, if you see here, now here there is a lesion which is low in signal intensity on T2 weighted sequence. So the epicenter of the lesion, now if you see, this is the peripheral zone on right side. This lesion is basically the epicenter is in the peripheral zone, but from there it is going into the transition zone. It is also crossing the midline and going to the right side, but from there it is breaching the capsule, and one can argue it is abutting the levator, and one has to be very careful if it is invading the levator itself, which can happen. If it invades the levator, it becomes a T4 lesion. But so we are at the apex, and now this is the tumor, this is the levator sling. We are coming posteriorly. As we come posteriorly, now this is the seminal vesicle. And if you see the tumor, actually all of this where I am pointing out is the tumor. It is going into the parenchyma, and we will see all of this on a sagittal very well. And one can argue that there is a connection. If you see this low signal, it is connected with this low signal bridge with the seminal vesicle. So even here, we have got suspicion that the left seminal vesicle is invaded. But we will look at other sequences. Now, on this, let's look for lymph nodes. And you can see lymph node here, you can see lymph node here, and look at this, lymph node here, lymph node here. So there are lymph nodes. On this T2 weighted sequence, not a good marrow, it is not very specific for marrow, but there appears to be something wrong, but we will not conclude anything. We will ask for a P1 for that. Before that, let's go for a sagittal. So this is a sagittal. Now I am on the left side, and you can actually see, look at this stranding. You can see it is breaching the capsule. Now here you are. This is the seminal vesicle, and you can see that the tumor is invading the seminal vesicle. Even here it is invading. Look, even here it is invading. And it is breaching the capsule on this side. So there is seminal. Now on a sagittal also you can see lymph nodes, and look at this one. This is a lymph node, and on the other side also you will be able to pick up lymph nodes. This is lymph nodes. These are lymph nodes, and on coronal, again the same findings. And you can see the lymph nodes here. Look at these lymph nodes there. Go for the DWI sequence, and this is the lowest p-value. As we go to the highest p-value, you can see this is the highest p-value. You can see this signal, which is that restricted diffusion, correlate it with the ADC map, and you can see that on ADC it is low signal. And finally, we can look at T1. And on T1, look at these metastases which are low in signal intensity. The formula on a T1 weighted sequence, it is true for anywhere in the body. Any signal which is lower on T1, lower than the adjacent muscle or lower than the intervertebral disc in spine, that is suspicious. Do a stir sequence, and on stir sequence, there might be, a high signal. But prostatic metastases at times are so sclerotic that on stir also they are low signal, and a bone scan will tell you the activity. So this was about prostate CA, and so this is one case which I have chosen for a bit of teaching today. Candidate 3, how many cases have you seen?
There are 2.
Okay, thank you, candidate
Thank you, sir.
3, well done. And now candidate 4.
Yes, sir. Thank you.
Over to you.
Okay. I'm provided with the frontal chest radiograph.
Let me give you the history. This is a 37-year-old female. It's a GP patient. The patient has got dry cough and she is known to be asthmatic.
I'm provided with the frontal chest radiograph of an adult female who came with a history of dry cough and asthma, and trying to look for the cause of the asthma and the dry cough. On the first glance, I can see that there is maintained volume in the bilateral lungs, and I can see that there is a opacity in the retrocardiac region, which is elongated in the midline region, extending from the mediastinum to the diaphragmatic level, and it is also extending below the level of diaphragm.
Can you point it out to me?
Yes.
You can ask for mouse.
Yes, sir. The questions of control.
Mouse is with you.
Can you see? That's it. See the opacity also.
Okay.
This opacity is adjacent to the ascending aortic shadow. So other than that, I'm trying to look for any mucus plugs, or I'm trying to look for capacities which explains mucus plugging, or I'm trying to look for
So what will you do next?
With this kind of opacities, I'm suspecting it could be a double aortic arch. So I would like to confirm these findings on post-contrast chest images.
What else can be your differential?
This could be I'm sorry, sir, I can't think of any, but it could be an aortic thrombus.
Okay, so let me give you a CT scan.
Sorry, inferior vena cava.
I've given you a CT scan. Over to you.
Okay. I'm presented with axial post-contrast images of the chest and abdomen. I'll go through the images before starting commenting. Okay. On the first scroll, I can see that there is an area of soft tissue density adjacent to the vertebra on the right hemithorax in the posterior mediastinum. this tissue density is extending over multiple vertebral levels, and it shows hypodensity in comparison with the muscle. I will compare with the non-contrast images for the enhancement. I don't see any obvious calcification in these soft tissue density. I'm looking at the breast shadows. I can see that the right breast shows.
Don't worry about the breast. That is known. That's a fibroadenoma.
So with this kind of appearance, I am suspecting a posterior mediastinal lesion.
What are you suspecting?
The patient came with a history of.
Sorry, what did you say? What are you suspecting? Can you hear me? I think we have lost you. Candidate? Maybe a connection is gone. So let me take over. So this is another case, which is a classical observation case. The candidate did very well, where picked up a finding here. Actually, if you see, this is the breast shadow. This is the breast shadow. This thing is the descending aorta, and easy to miss, but the candidate did well. That don't worry, candidate 4. Don't worry, I've taken over. So candidate did very well, where picked up this finding here. But the key thing is that what can it be? You know, it can be simply a posterior mediastinal lesion. And so here, the revision point as far as posterior mediastinal lesions are concerned will be, so this was an incidental thoracic paraspinal neurogenic tumor. And this is the differential diagnosis, which you should remember, 5.42. And, the posterior mediastinal lesions are divided into region 1, region 2, and 3. And this is region 1. This is a neurogenic tumor, which can be many types. They can extend into the neural foramen. There can be remodeling, etc. The same differential diagnosis is also included in this one, in the spine section, where, this is intraspinal masses, 2.17, and extra, what we call extradural, and then we have got intradural extramedullary. So now, chest X-ray was well picked up. Now on CT scan, we can see that the mass has got low density, and one has to comment on if there is, extension into the neural foramen. Maybe there is something here, but we are not very sure, and that is why we will ultimately ask for an MR. If you go to the bone window, must ask for a bone window to check for any scalloping, etc. In this case, there is none, but maybe a bit of extension into the neural foramen at this level. Just to highlight, if I show you a coronal, and you can see that how in a craniocaudal dimensions, how is the lesion? How big is the lesion? Actually, this was about 11-12 centimeter in length, craniocaudal. On MR, which I did not show the candidate, this is on T2, and it is intermediate to high signal, and this is it. And here, very close to the neural foramen, but not extending into it. So these can arise from the sympathetic chain, I mean to say. And then on post contrast, this is post contrast. I have not so this is pre contrast, fat saturated, and on post contrast, there you can see that there is enhancement, some enhancement. It's not cystic. It was low density, but not cystic. And on post contrast, this is it. So it is a classical neurogenic tumor, but was a classical observation film. Well picked up by the candidate. Well done. Candidate 4, are you with us or not? No. Candidate 5, are you with us?
Yes, sir.
Okay. This is a 59-year-old. So perianal pain, spiking temperature. Over to you. Can you ask for the mouse? Yeah,
Yeah.
Mouse is with you.
Thank you, sir. Sir, these are the T2 weighted MRI images of the pelvis of a male patient, and I am scrolling through the images. So in these T2 weighted MRI images, axial sections, I can appreciate in the region of the prostate, there is a T2 hyperintense lesion, which is located along the right posterolateral aspect of the prostate. This lesion is well defined, T2 hyperintense, and has some compression effects on the prostate. There are also T2 similar intensity signals within the prostate. The urinary bladder appears normal. The seminal vesicles also appear normal. The bones also appear normal in the visualized sections. So there are significant fat strandings along the periphery of the lesion. So my first differentials for this kind of imaging, I would also like to see the diffusion weighted images if available, and the T1 weighted images.
Diffusion.
Yes. Sir, I am unable to scroll through the images.
There's no need of scrolling, whatever was visible. So for example, you were looking at this thing here. So you are looking at this thing here, and it shows restricted diffusion.
Yes, I would like to confirm this restricted diffusion on the ADC images.
So this is the ADC.
So it means there is the restricted, these are low signals, and there is restricted diffusion. It's along the peripheral zone of the prostate. It is a DWI shows hyperintense corresponding ADC low signals, so restricted diffusion T2 hyperintense. So my first differential will go for that it's a malignant prostatic lesion, likely malignant prostatic CA. But there are significant fat strandings in addition to the lesion, and we also
have.
What
is the signal intensity of malignancy? We just did a prostatic carcinoma case.
So it's a hyperintense on the T2 and shows diffusion
You
restriction. So
know, just 1 second. We just did a prostatic carcinoma case, and I did a bit of a PowerPoint presentation. Uh, there, I told you what is the signal on T2 as far as malignancy is concerned. You remember that?
it should be T2 hypointense. So it's an inflammatory lesion and it's an prostatic abscess, which is T2 hyperintense and shows diffusion restriction. It's a prostatic abscess which corresponds with the history of the patient of the fever, and there are significant fat strandings along the periphery of the lesion. So it's a prostatic abscess. Uh, and I would also like to see the post contrast images for confirmation. So this is the post contrast.
Okay, that's fine. Thank you. Thank you. So the key point here is that I'm showing you another case. This is not the case which I showed you, but just to make a point. Look here on a T2 weighted sequence. This patient has got dysuria, fever, perineal pain, and it is a prostatic abscess. So the case which we just did was prostatic abscess. Now on T2 weighted sequence, it is fluid intensity as in high T2, and then just like an abscess, let's say a brain abscess, it will cause restricted diffusion. And then on post contrast, this is confirmed. So prostatic abscess itself is an exam case. So, and that is why the key point to remember is, the T2 findings. Of course, the clinical in this case was also in favor of infection, but if you see here, now we go towards the apex of the gland. As we come up, there is a high signal on this T2. And remember that an abscess, as correction, a carcinoma will be low signal. And then we see the DWI sequence, which shows restriction. And on ADC, this is it. And on post contrast, this is confirmed to be a prostatic abscess. Okay, well done. Now,
hello.
So over to you.
Sir, you are unaudible for the last 1 minute.
Okay. So I said that the last case was prostatic abscess, as you had pointed out. However, just a bit of fine touch is required regarding your description, etc. And otherwise, it is a prostatic abscess. Now, can you hear me? Okay, so this case is a 67-year-old male, right wrist pain. Over to you.
So this is the EP radiograph of the wrist, showing the distal parts of the radius and ulna, the carpal bones and the metacarpal bones. In this radiograph, it's a radiograph of a skeletally mature patient. In this radiograph, I can appreciate that there is a uh, there is a lucent lesion in the distal part of the radius in subarticular location. This lucent lesion is well defined, has a narrow zone of transition and sclerotic margins. So to me, it appears to be a less aggressive and it's a benign lesion, which is in subarticular location. Uh, so my differentials for this kind of lesion can be a GCT. It can also be a bone cyst, which is less likely. Uh, uh, and the next in the soft tissue, I can appreciate that there are some nodularity in the soft tissues of the uh, in the soft tissues adjacent to the radial aspect of the arm. This nodularity can be due to these are the neurofibromas or lipomas, most likely neurofibromas because
Okay, can I stop you there? There is nothing wrong in the soft tissue. What is happening in this joint here, the radiocarpal joint?
in the radiocarpal joint there is decreased joint space and there is uh, mm, subarticular sclerosis. There is scaphoid and lunate
Okay,
bones.
what is your conclusion? Then what about this lytic lesion? What is your conclusion about this lytic lesion?
Sir, my first differential in a skeletally mature patient subarticular well-defined lesions, my first differential will be GCT, and then
The,
this
the
is
age of this patient, I told you, is 67, just to remind you.
so it's a mm, sir, it can be a subarticular geode, and
Okay, we will stop there. Thank you. Now, this is a case for differential diagnosis. And this is a wrist geode with OA. Now, this is one of the most important advice for your exam in a differential diagnosis case. And in differential diagnosis case, a very easy case can become a very difficult case. And the key thing is that you should have clear-cut concepts about the differential diagnosis. You should know the list. For example, in this particular case, there is a list in Chapman, which is lucent epiphyseal bone lesion. And this is the list. So you should remember the list. And then the key point is that you have to tell the examiner the relevant differential diagnosis, taking in mind, keeping in mind the age, the location, the radiological features of the lesion you are seeing. So the examiner wants to listen to relevant differential diagnosis. Many of the cases, there will be a single diagnosis because of the clinical scenario, and so they do not want you to regurgitate the whole of the differential diagnosis case. This is what these cases are about. So very easy case can become a very difficult case. Now, please remember that in these cases, remember to be challenged by the examiner. They can ask you questions, what else can it be and what else can it be? So if you are very sure about about a diagnosis, just give them your thought process that I can also consider this, but however, because of this, it is not this. Can it be malignant? This can be another question. So whenever challenged, be confident. And please remember, at times this discussion can go on and on. Coming back to this differential, your talk about giant cell tumor, by the way, is not this age group. And number two, it has got non-sclerotic margins. Now, look at this lesions related to the pathology, and one of them is geode. There were signs in this case of secondary OA, and you cannot include chondroblastoma because of the age, and it was the clinical scenario, of course, was not in keeping with Brody's abscess. So in this particular case, uh, because of the what was happening around the joint, this is what it was. There is nothing else to be worried about unless there is a clinical scenario which is to the contrary. So this was a geode, simple case, but for differential diagnosis. So if you see here, look, there is a lesion which has got, which is lytic. It has got marginal sclerosis. Look at this joint. And this joint, the radiocarpal joint, there is very significant OA. Look at the joint space here. Then look at this lunate, and there is a cyst sitting there, and which can happen. So all of these things, the unifying diagnosis becomes a geode. I did not show you, and there was no need of showing you, but just to make a point that this is what it is on an MR. So lot of OA and subarticular geodes, quite a few locations. Okay, thank you very much. Next candidate. Candidate, is it candidate 6 or what is it?
Yes, good evening.
Good evening. So candidate 6, over to you. This patient is a 38-year-old male. The patient has got pituitary hyperfunction, and the X-ray was actually done to rule out any evidence, bony evidence of acromegaly. Over to you.
Yes, I have been presented with a lateral skull X-ray or radiograph for an adult patient searching for a feature of acromegaly due to pituitary hyperfunction. First thing I noticed that there is a lytic lesion seen in the area of the frontal bone, in the left frontal bone. I cannot see any other similar lesions. I can see that the skull bone thickness within normal limit. Sorry, and yeah, and because I am searching for changes of acromegaly, I can see that the pituitary fossa appear within normal. There is no enlargement of the pituitary fossa. Also, I can see that the sinuses showed normal size. I will confirm this also by the frontal view for this skull. In my routine practice, I will zoom, windowing the image. I can see that the size of the sinuses in the frontal, I cannot see actually the frontal sinuses. However, the rest of the paranasal sinuses appear within normal size. There is no enlargement of the sinuses. And in this case, I can see that the lesion is seen in the right frontal bone, and also showed sclerotic margin. In this image, I cannot see any perosteal reaction within the skull bone.
So what is this lesion then?
Yes, this lesion, it could be due to because of the history of the pituitary abnormality or hyperfunction. It could be due to benign lesion, it not showed aggressive component. It could be due to changes of budget, although this patient is young in age, so less likely. Other, it could be due to bony lesion due to the changes of Langerhans cell histiocytosis. Also, this is an adult patient for this diagnosis. It could be due to metastasis. So I will check if there is any history of primary tumor elsewhere, and I will.
There is no history.
Okay. There is no history of metastasis. It could be due to intracranial lesion that causing erosion of the skull bone, such as benign slow-growing lesion, like meningioma. It can cause this appearance of erosion.
Meningioma will cause this kind of erosion, this kind
Yeah,
of.
if it is benign and slow-growing, maybe. Yeah.
Okay. So anything else in your differential?
No, sorry.
Okay. So fine. Thank you. And this was another very simple case which becomes very difficult in the exam, and because it is for differential diagnosis. And this is a skull epidermoid. And you know the differential diagnosis in your Chapman, there are two differential diagnoses. One is skull wall lucency with sclerotic edge, and then another one is this one, skull wall lucency without sclerotic edge. So the sclerotic edge means that it's a slow growing lesion, unless if it is an aggressive lesion, then it is post treatment. So for example, if you see the differential diagnosis, skull wall lucency with sclerotic edge, these ones are normal variants, and our case was not at all in this territory: venous channel, venous lakes, arachnoid granulation, developmental. Epidermoids, intradiploic, rare, well-defined scalloped margins similar to CSF on T1, T2, but restricted diffusion and incomplete suppression of flare. So MR has got a bit of role there. And of course, meningocele, encapsulocele, etc. can cause this. Neoplastic lesions like Langerhans histiocytosis, by the way, as you pointed out, this is not the age group, etc., only when it is treated. Otherwise, it is more aggressive. It will not cause marginal sclerosis. Marginal sclerosis means that it is long standing. And as far as metastasis is concerned, only if they are treated. Chronic osteomyelitis, only, of course, the clinical will be there. So there is indirectly a finite type of differential diagnosis in this case. Clinically speaking, if you would have gone into this territory, I would have said that no, there is no history of this, of metastasis. No, of course, clinically it was a completely incidentaloma. It was not at all no bone, what we call pain, etc. This example also tells you that at a very simple case, how difficult it becomes for differential diagnosis in the exam. So there are two parts of it. First of all, you have to remember your differential diagnosis, and then considering the age, considering the clinical scenarios, etc., you have to tell the examiner what is relevant. Now, epidermoids can so this particular case, this is the CT scan of, and you can actually begin, the examiner can begin with the CT scan, simple as that. This is quite an old case in our department, I think more than 15 years old, 2000 something. And somebody asked for a bone scan. At that time, I think MR with diffusion was not all that common. And on bone scan, it did not show any uptake. So indirectly, because of this, it was said that it's a benign lesion, most probably epidermoid. But in this era, go for an MR. This is another case from my collection where this is an epidermoid. This is it. And when you go to T2, it is fluid intensity. And on flare, there is a bit of signal inside. It's not fluid. Fluid will be low signal. And this is what the Chapman told you. Ask for diffusion. So the examiner will show you this and go for diffusion, and it will cause restricted diffusion. Please remember, epidermoid is the same thing as a cholesteatoma in the temporal bone. Within the brain, within the cranial vault, other than the temporal bone, we call it epidermoid. Within the temporal bone, we call it a cholesteatoma. Cholesteatomas can be acquired and it can be congenital also. Similarly, these lesions can be congenital. So ask for a DWI sequence. And just to make a point that this is Langerhans cell histiocytosis, and just concentrate on the marginal sclerosis, and you will agree that there is no marginal sclerosis. Of course, this patient has got so many of them. So I'm not teaching you more, lesions here, but just to make a point that lesions without sclerotic edge, and they will be slightly more aggressive. And so, for example, neoplastic in adults and neoplastic in children, and then traumatic and metabolic in acute infection, etc. So, with sclerosis, without sclerosis, the differential diagnosis changes. This is the key point to remember. And this is another example where a very simple differential becomes quite a difficult one in the exam. Okay, so next case, please. So, candidate 6.
Yes.
I'm going to scroll this for you. Let me tell you the history. This is a 36-year-old female. The patient has got chronic diarrhea off and on, and she has lost weight, history of abdominal pain, vomiting, and chronic diarrhea off and on. With that, we have done an MRE examination. Excuse me. And I am scrolling it. You want to take the mouse?
Okay. I will ask for remote control.
Yeah. Over to you.
Okay.
So forget about this sagittal. Don't look at this sagittal. Yeah.
Okay. So I have been presented with MRE study for a middle-aged female patient with history of abdominal pain and chronic diarrhea on and off. I am looking through the examination from the start until its end. I didn't catch any abnormalities, so I will go through my checklist. I can see that. I can see that there is thickening and neural irregularity seen involving the transverse colon. Started from the hepatic flexure, and the transverse colon itself, it's appear
Just
redundant.
concentrate on the small bowel, please. Just concentrate on the small.
Yes, I will start looking by the to the stomach, and then I will go into the duodenum. I cannot see any obvious abnormality within the stomach wall, and I can see that there is the jejunum. All of the jejunum is seen on the right side of the image, and showed the normal valve convenitus, and also I can see that the ileum is clustered on the left side, which show less valve convenitus. So this rule out the celiac disease, because I can see that there is no reversal of pattern between the jejunum and the ileum. I can see.
Sorry, what did you say? This rules out what? Celiac disease?
Celiac disease.
What do you mean?
In celiac disease, there is a reversal on the fold pattern between the jejunum and the ileum. It's called jejunism of the ileum, and
So
it will.
how have you inferred that? Where is the jejunum? Where is the jejunum and where is the ileum in this case?
Yeah, I tried to trace them. I saw that after the stomach there is the duodenum here, and it's appear connected to the jejunum over here. And
okay, just 1 second, please. 1 second.
Yeah.
Over to you.
Okay. So this is the axial images T2 for the same patient.
And I can just 1 second. I can also give you the upper abdomen. So this is the upper abdomen. Over to you.
Yeah. So I'm starting with the stomach, and I will trace it into the duodenum. After the duodenum, I am now seeing the proximal segment of the jejunum. I can see that the jejunum is clustered on the right side. This is
just 1 second. Just 1 second. Just 1 second. What is this?
This one?
No, this structure where I'm pointing out.
Let me give you back the mouse because
your mouse. You don't move the mouse.
Okay.
I'm moving. What is this structure?
This is the pancreas.
What is this?
The duodenum, which is
which part of duodenum?
Third part of duodenum.
And
yes, yeah. I can see now that the third part of duodenum do not cross the midline, and it go back into the right side. And as I say, so that the jejunum is clustered in the right side. This could be representing a case of malrotation.
Malrotation.
Yeah, because the duodenum, the third part, didn't pass onto the left side of the midline, and it's seen on the right side.
Right. This case, what else will you like to see in a case of malrotation?
I want to see the superior mesenteric artery and the superior mesenteric vein to see the relation between the two of them. Yes. In this image, I can see that the aorta bifurcation, no.
Say again, please.
Yeah, I want to see start from the aorta and the upper abdomen, and then to assess the position of the anterior and the superior and mesenteric artery and vein.
Right. So you have diagnosed a case of
malrotation.
Malrotation. Now, the key thing in malrotation is jejunal junction, right?
Yes.
So in this case, if you see here, this is your superior mesenteric vein. This is your superior mesenteric artery. This is your jejunal junction, and it is impinged here, and then it goes to the right side. So you are right that there is a malrotation there. that is fine. Last case for you. Sixty 9-year-old female, 69-year-old female, which has got unwitnessed fall, hit her head on the floor, persistent vomiting, and she is on blood thinners. So they have said rule out possibility of intracranial hemorrhage.
Okay, so I have been presented with axial images of brain CT scan without IV contrast for a 69 female patient with history of falling down on her head with vomiting. She is in blood thinner. I will go through the sequence until the last cut, and then I will come back to my finding. Okay. I didn't pick up any abnormality in first inspection, so I will go through my checklist. In these images, I cannot see any intraaxial or extraaxial blood hematoma. Also, I can see that there is no shift of midline structure, and also I can see that the ventricular system within normal. I cannot see any blood collection within the basal cistern. In my routine practice, I want also to see if there is any bone fracture. So I will change this window into the bone window. Other than that, I want also to check the sinuses to see if there is any air blood levels. I can see that the sinuses appear clear. There is no blood seen in the sinuses or the nasal pathway. I can see that the mastoid cells are pneumatized well bilaterally.
Okay, just 1 second, please. 1 second. What do you think is happening here?
Yeah, you mean this lesion?
Yeah.
Yeah. Here I can see that there is a well-defined hyperdense lesion noted at the right parietal lobe posteriorly. I cannot see any similar lesion in this cut or in other cuts. This mass lesion didn't show any perilesional edema, and also didn't show any space occupying lesion or compression onto the adjacent right ventricle. My impression for this case, it could be a case of cavernoma. Other differential.
What will you do?
For confirmation, I will ask for MRI to see if there is signs of surrounding hemosiderosis and Sherry berry-like mass lesion.
Which sequence will you like to see on MR?
I will start with T2 sequence.
T2 for you?
Yeah. This is a T2 sequence brain MRI for the same patient. In the location of previously seen lesion, I can see the hypointense T2 layer of hemosiderin with hyperintense lesion, which confirm my diagnosis of cavernoma. In my routine practice, I want also to check the rest of the images to see if there is any similar cavernoma in this study.
Which sequence would you like to see for that?
SWI. Yeah, in SWI, I can see that this lesion causing susceptibility artifact. Okay, I will scroll quickly through the image. Until now, I cannot see any similar susceptibility artifact. So there is only this one lesion of cavernoma. In my routine practice, I will check the system if there is any previous images for comparison. If not, I will confine my finding to the referral doctor.
What else would you like to suggest?
For this patient?
Yeah.
Maybe follow up.
Why do you want to do a follow up?
To see if to rule out any complication.
What kind of complications are we talking about?
It could lead to hemorrhage or hematoma in the brain.
Okay, we stop here. Thank you. Now, this case, candidate did well where, picked up this hyperdense focus and then asked for an MR. On the MR, now on the T2 weighted sequence, key finding about a cavernoma. Please remember the basics about a cavernoma. Vascular malformations are various types. Cavernoma is one of them. Another one is known as DVA, developmental venous anomaly. DVA and arteriovenous malformation and dural fistulas, etc., are the other types. Cavernoma is very important for the exam. Cavernoma is very important for the exam. And why is it important? Because cavernoma, it all depends how big it is. It might be small. In that case, it will be just seen as a hemosiderin, signal, or particularly on a SWI sequence, it will show as a blooming artifact. But if cavernoma is slightly big, it might show a hemosiderin rim, and within that there will be hemorrhagic foci of various ages. So it can be high signal on T2, and then if you look at the T1, you might get some high signal, and in this case we can see that there is a high signal within it. But the key part is that hemosiderin rim. Cavernomas, now another concept to remember is that it's a good idea to look for multiple cavernomas. Age of the patient is one of the key. There is no role of follow-up scanning. Please remember that. But having said that, cavernomas can increase and decrease in size with age, which is very unique behavior. But the key exam concept is that about 30%, 20 to 30, 25%, some studies told us about 30% of cavernomas are associated with developmental venous anomaly. Developmental venous anomaly will be picked up on post-contrast sequence. Don't confuse it with an angiogram. Just do a post-contrast and you will see it. So in the exam, you can tell the examiner that I want to do a post-contrast, not to diagnose cavernoma. Cavernomas are not angiographically occurred. You just diagnose it on usual sequences, but I want to rule out or to pick up any associated DVA. Will it change management? No, it will not change management, but this is just an academic exercise. So this is, I think, the last case of the day. So all said and done, we did manage to cover the 12 cases which I had, and of course we did spend a bit of time on prostate imaging. In your feedback, if you want to do some dedicated sequences for particular thing, you can ask me. Dedicated sequences, for example, temporal bone imaging, or neck imaging, or if you want to do something like what we call MRs, dedicated MR prostate, rectum, body MRs, which are important for exam. We can do that kind of session also, mixed with potpourri. Potpourri session gives you a taste of everything. Today we did chest X-rays. These were classical exam cases, and which are observation films. And many a times these might be the first case in the exam, observation film. And but you also, one of the key points which I want to highlight is that a very simple differential diagnosis becomes a difficult case if you don't handle it correctly. Remember, I showed you a geode, I showed you a lytic, that epidermoid. So in you have to really develop your skills. Remember the differential diagnosis, but develop your minds to be able to just tell the examiner the relevant differential diagnosis. So in your feedbacks, if you want uh, any special sessions like temporal bone, neck, head and neck is a difficult one. Anything from there, we can do dedicated sessions, and similarly, we can do dedicated MR sessions also if you want. So, just 1 second. I think. So another thing which is coming up, 22nd of this month. Don't miss this session, which is RCR's concept of realm, which is on 22nd. This will be just first part. Please remember that my vision is that those of you who are interested from overseas, we will present the concept in the first session. We will show you cases also, and you will see. Actually, I will show you my own mistakes, which I have done over the years, and how do you learn from your mistakes. And I will show you cases which you will find very good cases for your 2B exams. So learning from your own mistakes. So this is, we are going to do it on 22nd, the first part. Then we will do a second part, and we will invite anybody out of you who are interested. We want to continue this in future also. So don't miss this, and this will really help you, and your departments for the future. So this is a special initiative which we are taking. It will be a ongoing series. So don't miss this. This is on 22nd. And this course, which is a Viva course, intensive Viva course, where you can get face-to-face personal Viva practices, 6 Vivas, 4-hour duration, and you can attend 8 hours Vivas as observer. This is the email to register. This is dubaifrcr@gmail.com. This is many of our faculty are taking part. It's not DKT course, but our faculty is going to conduct this. So these are two things which are announcements, and this is the feedback form. So thank you very much. I don't have time to take any questions today. So best wishes. And yeah, okay. So how do you differentiate between micro hemorrhages? You cannot differentiate between micro hemorrhages. Maybe both of them will show blooming artifact. So small cavernoma versus cerebral amyloid angiopathy looks like similar, except that age or the clinical scenario will be different. So you on SWI sequence, they can look similar. In any case, I don't have time today to take your questions. So I take my leave and see you next time. Thank you.